Eddie Kilbride with Kilbride Plastic Surgery. Today's patient story, the case of the curious index finger. So a lot of people think that their index finger is critically important. I'm not here to say that it's not, but I am going to illustrate with this case how the index finger is a remarkably dispensable digit in that the long finger serves as a ready and extremely able kind of second string quarterback in the case that the index finger needs to be sacrificed or used for other purposes. And that's what we'll illustrate with this case. So this is a patient who's 77 years old and right-hand dominant. Now, 10 years ago, at a neighboring institution outside of Kaiser, he had a thumb IP joint level amputation from a melanoma of the thumb. Okay? And patients can do pretty well with a slightly shortened thumb. It's not ideal with regard to the thumb. Length preservation is key. But he'd been living like this for 10 years without an IP joint, but he still had enough length that he can do all of his activities and was happy. However, he developed a recurrent lesion at the thumb, as illustrated here, and he was sent to me from one of our Kaiser hospitals outside of our region with the question of, hey, can you do anything to treat this melanoma recurrence, which is a melanoma-in-situ here, and also preserve length, because we don't want to shorten his digit anymore. Can that be done? And so that's the case of the curious index finger. So this patient's 77 years old. He has a history of lung cancer that has had partial lung resection in the past. He had a heart attack 2 years ago, has had stents. He's not someone that we want to subject to long, extensive general anesthesia procedures that could compromise his overall health. And so I talked to him about a number of options where we could resect away the melanoma and preserve all the length and get coverage. One option would be an FDMA flap from the index, but that wouldn't be large enough. Another great option would be a toe transfer, but the patient was not interested in that, and that's also a pretty lengthy general anesthesia procedure. And so I proposed to him, what if we take your index finger, use the skin from the index finger to cover the wound, but also add bone length, add a joint, make it sensate. And there's really no better like-for-like reconstruction. You need thin, you need a nail complex. We're going to add a joint. It's even better than before. And get soft tissue coverage that's thin and pliable. And so he was definitely agreeable with that. This allowed us to do this procedure under a block with much less anesthesia and much faster. So better for the patient. So here he is on the table. We performed a bone-sparing excision to clear margins. Obviously, I'm verifying clear margins before proceeding. Here's just the markings illustrating. I'm going to make bone cuts at a level distal than I am going to the skin cuts. This is not the same as a policization procedure that's commonly seen in a pediatric population. It's more of a hybrid heterotopic transplantation, really. Of course, I'm going to use the contralateral thumb to get a sense for how much bone length we're going to need. And here's the dissection. So under tourniquet control, you can see that the index finger, I've removed the proximal phalanx. As shown in both images, you can see that how much of the soft tissue deficit is on the thumb in that picture on the right. The index finger is isolated entirely on the neurovascular bundles of the artery and the vein, and the artery and the nerve on both sides, as well as the tendons as shown in the picture on your left. And on the right, I divide the FDP tendon and the extensors in preparation for moving the index to the thumb position and resuturing those tendons to get some function there of the index. And here it is. The finger is isolated on the neurovascular structures alone here. The veins on the dorsal side, the two neurovascular bundles on the volar side. And then it is transposed to the thumb position. Again, this picture really highlights that the bone cut, which you see here, where that black line is very different from where the skin coverage point is to get coverage of that wound. So we're not only covering the wound, but we're adding length, we're adding the joint, we're adding function of that joint through the FDP and the extensor tendon, and we're making sure it's sensate, adding the nail complex, etc. And then here it is shown kind of rotated into position. And finally, the on-table result, you can see it's nice and pink. It's got great blood flow. Did not have to disconnect the arteries for this. Okay, this isn't like what we commonly do with replantation, but did connect the flexor tendon to the FPL, the extensor tendon to the EPL tendon. This just illustrates the bony fixation on X-ray. Here he is at 6 weeks, and here are some of his outcomes. Here he is at 6 weeks.
Okay, good. And then can you touch your index finger? Just got the pins out. Excellent. And then open up again. Perfect. And then can you make a fist? Best you can, make a fist. There you go. And open up. We just got the pins out. We haven't even done the therapy yet. So turn this way. Very good. And then back this way. And then see if you can touch your middle finger. Good. And go for the middle one. Excellent job. Good. Okay, we'll get you there. We'll get you there.
And here he is at 10 weeks post-op.
Using chopsticks. So let's take a look at you. You're 10 weeks out. Can you turn this way for me? And then can you bring your thumb down like this into your palm and then straighten it back out like a thumbs up? Excellent. Can you touch your small finger almost? What, your ring? Excellent. And your index? Perfect. And then open up in this way. Perfect. And are you able to grab simple objects and open? Yep. Yeah. Awesome.
Yeah.
And how's your feeling here? Do you have feeling here?
Yeah, I do. Yeah.
And on this side also?
Mm-hmm.
Excellent.
So I hope you enjoyed this case, or the case of the curious index finger. I think this case illustrates the right solution for this patient. I'm certainly not advocating that we sacrifice the index on every patient, but for this patient, 77, wanting to avoid the issues with toe transfer, etc., this really provided an elegant solution, re-amputation of the index with transplantation to the thumb position. As always, make sure your surgeon's board certified. Ask for pre-op and post-op pictures. We'll see you for the next patient story.